morning. They always put me just before the lunch to make you hungry. My name is Amir مراد. I'm a plastic and craniofacial consultant from Riyadh, Saudi Arabia. I'm also an assistant professor at Al-Faisal University. Today I'll be talking about Vicross technology with fillers of the face. What we'll do, I will talk about beautification to start with, then introduce you to my technique, and then best practices, and then we'll do a live demo on 2 models. So now we'll shift to the live demonstration. I'll show you my technique. I'll try to do the best practice throughout. I'm not sure we'll call for a break. Just give me 2 minutes to set it up, and we'll be with you shortly. I think we can open the house for questions. I can answer while I'm preparing the patients for them.
Thank you very much, Dr. Amir. Very informative. I'm sure you have a house full of people who inject. So
yes.
many questions. Dr. Amir will receive questions while he's preparing for the live demo. So feel free to ask. We have a mic on stand. Any questions?
Don't be shy. Just ask. If I don't know, I'll say I don't know. There are much more senior تورطنا. I'm dead.
Thank you very much, Amir. Very thorough presentation.
Thank you.
I wonder if you can tell us how to inject on top of a filler of an unknown origin or a filler of a different kind. Can you mix 2 types of fillers?
Very important question, actually. If you don't know the product, I would assume it's a permanent product, because the patient usually know their products, or you can ask who injected your fillers, and most of us know in their town or their city who injects permanent fillers and who doesn't, right? So if you don't know and the patient doesn't know, I would not inject on top of that, because I would assume that's a permanent filler. I don't treat permanent fillers, I don't remove them, and I don't inject over them. I tell the patient, that's it, you had your 1 chance and you've ruined it. In terms of knowing the product, so any product that is dissolvable, whether hyaluronidase or calcium products, you can safely inject hyaluronidase on top of them. As you know, hyaluronidase is a natural product, so it's fine to inject them on top of other products. There are no contraindication from different companies to use different products. So I don't have any problems injecting over non-permanent products. I tell the patient that there's a possibility of infection. I'm not sure if it increases or not in such cases. But that's always there, right? And if you have the product initially, and if you inject it again, you might inoculate that previous product that is stable and fine with that small bug and cause infection. How are we on time? We're done. That's perfect. Thank you.
We need to start the injection.
Sure. Aywa.
Since we want to inject with the hyaluronidase, with the hyaluronic filler.
Yes.
Hyaluronic acid filler. What's the contraindication of injecting, for example, the legs of a pregnant lady?
With hyaluronic acid? There are no studies that show on humans the safety of these products. So for me, I don't inject them at all. Yes, I know. I know. But just because we don't have enough studies, you know, it's better safe than sorry. I don't want to be that first study in my practice. You're welcome. Gloves? I have gloves, yes.
Now we have experienced more granuloma of hyaluronic acid, and we have seen in our clinic, even from Jupiter, since you are injecting that substance.
Yes.
Is there any under publication that people they are not
give me one of each.
They are not
Give me one
reporting
of each.
and the reporting or technique or manufactured errors, or why we are seeing more and more and we are hearing more granuloma from the hyaluronic acid?
I think the main reason for having granulomas is not being meticulous while injecting, and injecting more superficial, the product more superficially and in boluses superficially. So I'm against injecting superficially with boluses. I go deeper with boluses. So that's number one. Number two, the products, I'm not sure about different manufacturers, if they have changed their linking and product manufacturing to cause these granulomas. But if that's the case, we would see it in our practice as well. But I'm sure in your practice, these granulomas are not as much as the more junior injectors or outside of your clinic. And the good thing about these products is that if that happens, you can treat it safely. Sweaty a little bit. كيف حالك? So first we'll start with the consultation. I'd ask the patient what are her main concerns. We had this consultations behind the screen. But in terms of facial features, what would you like to improve on?
Of course, the cheeks.
أيوة هنقدم عشان الميكروفون.
Cheeks. First thing.
Yes.
And also the chin here.
So as she's talking and telling me all these areas, I'm thinking, does she really need that? And I do agree with her on the cheeks and the chin. She has a protruding chin, as you can see here. She doesn't have a mental crease, so she'd benefit from the product there. Also the cheeks. Any other areas of concern?
Here, this area, I think.
Nasolabial folds,
Yeah.
I agree. It's tricky with our model today, Hiba, to treat the nasolabial folds because of the protrusion of the upper and lower lip. So there, she has a maxillary protrusion, and that might be a little bit tricky. And it's difficult to see it on the camera and also on the photos that I've seen for the patient preoperatively. So you need to be careful and maybe minimize the product in that area just to camouflage the upper half of the nasolabial fold. Also, the most important point,
Yeah.
I will mention it because that's the first thing I've seen when I've seen the photos is the lower eyelids.
Yes.
So the hollowness under the eyelids. The best treatment, of course, is surgical, but today we're talking about injections, and we can camouflage with fillers in the area. And again, it's a safe product, and we use it just underneath the muscle. Okay? Other areas that we're going to inject and discuss are the angle of the mandible. This is, again, a common trend, and we've discussed the trends with the patient. She would like a more structured face, وجه منحوت أكثر. You don't like the chubby faces like my patient from the north, right? Okay. So, again, I use clean gloves. They're not sterile. The patient has prepped, the nurse has prepped the patient with alcohol swab, and she's been treated with eutactic mixture of local anesthesia just for the sake of time. As I mentioned, I start injecting the bone first. I'll shift it a little bit so you can see with me. I sterilize the area that I'm working on. So here, that's the cheek injection, voluma. I use sharp needles in this area. I've worn the lab coat and the scrub suit today to demonstrate that as well. I removed that before the treatment. I just forgot, very anxious. You need to have, you don't want to transmit infections with your gloves. I've sterilized the area already. I have alcohol swab all around me. She's ready with alcohol swab as well. That area hasn't been touched again. And so I point out the area, maximum protrusion, and I go in with one puncture hole all the way down to the bone, okay? And I inject my bolus on the bone. I aspirate before injecting, and then I inject directly on the bone. Do you feel any pain?
No.
Okay, perfect. So I inject 0.2 to 0.3 in that area. I do not come out of the skin. I just pull out a little bit. I'm not sure if you see that on the screen. I tilt my needle medially. Again, hit the bone, and inject the other bolus. So it's similar to the MD codes, but I just don't like the multiple injection sites. This not only treats the cheek, it treats the lower bags laterally, not medially. And then the last part, again, I don't come out of the needle, and I go medially. So you're drawing that cheekbone, okay? And you can see here, I inject on the bone. I'm not sure if this is clear. Another 0.2 to 0.3 on the bone. So that's almost a full needle. And I think you need, I use alcohol swab again. Some of you would use a gauze here to clean the blood. I use alcohol swab. I might massage the product just a little bit to spread it. Yes. Was she to
Do you need to
aspirate? Yes, I mentioned that you have to aspirate before injecting, no matter where you're injecting. It's not in the danger areas only. Always, best practice is to aspirate. So now if you tilt your face forward, and you can see that already she has a more prominent cheek on that side in comparison to the right side. So I'll inject this half first, all over, and then we'll inject the other half, if we have time. The second area of concern is the angle of mandible. Again, that has been anesthetized with EMLA. Sterilize the area. Don't sterilize and retouch and repoint. Understand your anatomical landmark beforehand. Here I'd like to identify, give me a red marking pen. I'd like to identify the vessels. So in the cheek, we do not have any danger area around the cheek. But when we're moving down to the angle of the mandible, and later to the nasal folds, you need to identify those vessels. So it's midway in between the chin and the angle of the mandible. Somewhere here, if you feel with your finger, you might feel that pulsation. Okay? There it is. So that's the facial artery. It crosses the angle of the mandible, artery and vein, and goes all the way up here, gives you the superior labial artery, inferior labial artery, and then continues, usually lateral to the nasolabial fold. And goes all the way lateral to the nose. We see that when we're doing our rhinoplasties, and then it connects with vessels in the glabellar area and in the eye. So you need to be aware of the course of this. I'm injecting on the chin, I'm injecting on the angle of the mandible, I'm not injecting in this area. Usually you don't need to inject this area because you have the jowling in your patients, and the jowling is in this area, so you don't want to inject in the jowls. You might need to liposuction the jowls instead. So inject pre-jowls and post-jowls. Again, voluma. I've identified, I've cleaned, I think you've seen on the screen how many times I've cleaned. I think it's turning to a psychological problem to me. So angle of the mandible, I've not touched the areas I've sterilized, identify the angle, and go directly all the way to the bone. The patient might feel this injection in her teeth. Okay? I tell her that's fine. If you tell her, she'd feel much better that you're not doing anything wrong. And I inject the amount needed. So we've discussed this preoperatively. I need almost a bolus in this area, a full cc. So I go 0.5 at the angle. There you go. And then mobilize your needle. So same puncture hole. I did not come out. And then go more anterior on the bone. She's felt it. You can see her grimacing a little bit. Aspirate so you're not on a vessel. Inject 2.5 cc's anteriorly. And then again, manipulate your needle. Stay in the skin. This decreases infection and pain. And I'm go superiorly, again, on the bone. All my needles in this area are on the bone. Aspirate and then inject. Perpendicular in the first site, and the other sites are a little bit angulated, just because I don't want to puncture her again. If it's always perpendicular, you're puncturing the skin more times. Okay? An important point to talk about, is that these needles, they're very fine needles, right? And if you hit the bone with them, you might blunt the needle. So if you're using the same needle on both sides, what I would do, I might ask the nurse to change the needle. So this is done now. We don't need to change anything. But if you're going with half an injection on each side, I would change the needle if you're hitting the bone. Because if you go through the skin again with that same needle, the patient will feel pain. Okay? So let's raise your face ahead. Here, raise your head up a little bit. You can see the elevation of the jaw. If she turns, you can see beautiful demarcation of the angle of the mandible. So what I'm trying to do when I'm injecting, you can see less definition on this side. I think because of my practice as a plastic surgeon, I do facial implants. I put permanent facial implants, whether silicone or porous polyethylene. So what I'm trying to do with these injections is to simulate that implant. And hence, I try to get the same results. And it's the same thinking process for my fillers and my implants. If the patient needs a small implant, it's usually a half to 1 cc. If it's a medium-sized implant, we have small, medium, and large. Very simple again, 3 products. The small, half to 1 cc. The medium is 2 cc's, and the large is 3 cc's. Okay? So we've demonstrated the cheek, we've demonstrated the angle of mandible, and now we'll go to the chin. As I mentioned, she has a retruded chin. I want to simulate a chin implant for this patient, alcohol and voluma. Some people go from underneath the chin, some people go directly, some people have multiple holes. Again, in my practice, I go 1 hole on the face. I do it in the midline. The midline is usually avascular, and the amount of fillers that I would need to inject here to start seeing the results is minimum of 2 cc's because of retrusion. So I'll tilt the patient a little bit so you can see the needle. Okay, so I pinch the area. I always pinch, whether Botox or fillers. I think it makes it more comfortable to the patient where you're not dragging the skin and pushing the skin. I sometimes see videos or other doctors injecting with one hand and trying to do something else with the other hand, whether pressure on the patient or using these vibrators. Yes, nerve distractors. I can't see me doing that in my practice because I always, as you've seen here, I always hold the area, and that will not cause dragging and will cause less pain to your patients. Yes. Much less painful. At all. Okay, so here on the chin, midline, inject all the way down to the bone. I hit the bone, I've hit the bone, I've blunt my needle, and now I'm injecting, aspirate, and then inject. And it's usually, you felt it in your teeth, I think, right? Mm-hmm. Yeah, I see that flinching. And I inject that whole cc. I've discussed with Hiba prior to the injection, her desire on the chin. Does she want a more rounded chin, or she would like it more pointy? And she said more pointy. So I put 3/4 of the needle in the midline, and then the last quarter I would spread. Again, the fish here, it's difficult with the needle in the face. Okay, you see that? So I pull it out, not out of the skin. I angulate it medially and laterally. She might feel a little bit of pain in this area because of the mentalis muscle. In the midline, the mentalis has an arbitration of it, and it won't cause any pain. But laterally, she might feel a little bit of pain on the muscle. Again, there are no vessels or nerve in this area, so you're usually safe. It's just the muscle that she might feel and flinch a little bit. Okay, so that's a full cc, and we'll see the patient together. I will need another injection. You can see, see some contouring. Yes, some contouring. She was much more receding, and I said that before treating, she would need another injection, 2 to 3 minimum. So let's have another needle. I'll do that faster. How are we doing with time?
Very good.
Good. Okay. Good.
I think at this point it's always a good time to give your patient
The mirror, yes.
And tell them, look at this side, the one I've done, and look at the other side. Because once you're done with the other side, they can't see the difference.
Perfect.
This is a good time to make them appreciate your work.
Yeah. Okay, so again, I've sterilized this area. أعطيني alcohol swab again. See? Obsessive compulsive. Sterilize the area. Same puncture hole. Try to get the same puncture hole all the way down to the bone. Same technique. Most of the bolus on the needle. Sorry, let's turn a little bit. Okay. Whole bolus in the midline. And because it's deep on the bone, they would not develop lumps or granulomas in the area. And the product will spread just below the periosteum. Whole CC. Are very happy. Yeah.
Especially women who work hijab or cover the head. The chin area is an area that they always look for to improve. It's a very simple one.
Now you start seeing that coming out nicely. Okay? So I've tried to take one model and to do all the treatments on her. She does not need any filling in the lips. She might need surgery to reduce parts of the lips to do what we call zemm shafaif or pursing. But that's it. So these are the 3 sites. Give me gauze, please. It's important to know that when you use alcohol swab to eliminate your infection, every time you swipe, bleeding will come more. So what I can do, I put an alcohol swab or use alcohol swab on my gauze and apply pressure. You can ask the patient or the nurse to apply pressure in the area. Okay, so voluma, or heavier products. The heaviest product on the cheek, angle of mandible, and chin. I'm not sure if you see this on the video. You can see some grooviness just above the filler. That's fine. I said you can either try massaging the area, but don't panic. What you can do is ask the patient to come back in 3 days. This might disappear completely. They would look a lot better. The swelling has taken effect. The product has melted and not melted, but distributed itself in a better way. So I wouldn't panic. I wouldn't inject her more, especially that we've done the budgeting beforehand, right?
What's your views on massaging? A lot of doctors massage a lot. I personally think you should not. You should
Yes.
just press and just make a little bit of pressure if you want, but don't over-massage what you've just injected.
I agree with you totally. This is for the doctors, not the patients. So I ask patients not to massage. They don't know what they're doing. So no massaging whatsoever. It's the doctor who does a massage. Initially, if you see that the product has accumulated a little bit more in one area, you massage it. Otherwise, I wouldn't touch it if it's good.
Patients will ask you about what
Of course.
they agree with. Shall I
Massage it,
Shall
shall
I
not.
put cold compressors?
Yes.
Shall I put hot compressors? So I think
Nothing.
you should not do that.
Not do nothing to the face. Okay. Just for the sake of time, I'll continue injecting this side with the other areas. So we'll have Vol lift, please. The other area I'll inject. So these are the sequence I do. First is the structure, bone. Second, subcutaneous tissue. Third, submuscular tissue on the eyes or the lips. Okay. So in the nasolabial area. No, just a needle, a sharp needle. We've mentioned the vessel. So this is your nasolabial fold. You should go always medial to that area. I only treat the upper half of the nasolabial fold area. I do not treat the lower half. She does not need treatment actually in the lower half. She has fullness in the lower half that I might improve on when I inject the upper half. Okay, so that's the site of the vessel. Again, you can inject in the vessel, but just be aware of that. Tell the patient it's in your consent, and be much more superficial. Okay. So here again, I use both hands, and here is crucial. So I've delineated my nasolabial fold. If I haven't done so with a marking pen pre-op, I would push slightly on the patient's face, and you can see that fold developing, right? So when you see that, you just want to go medial to it. If you go lateral, you'll hit the vessel, you'll augment her nasolabial folds. You're actually causing the patient more damage than good. Okay, I pull on the skin, one puncture hole, and then subcutaneous. I start with the angle, I aspirate, it's crucial to aspirate in this area, and then I inject as I'm pulling out. Usually in the nasolabial fold, I do a half cc. Every time I push in, I aspirate and then I inject. Usually it's a half cc fanning technique. It's a little bit painful to the patient when you go, when you touch the muscles in the area. In our model today, we don't want to overdo her because of the fullness of her lips, both white and red. You can continue doing your fanning technique to augment the area. You might come out and assess, and then a few seconds later, you inject again. Your product, if it has xylocaine in it, she would not feel pain. And that's it. So, no massaging. I tell my patient that they might feel a lump in this area. I think it's natural to have a lump in this area just because of the small size of the area that you've injected. If you compare right to left, that line, marking pen, completely gone. Completely gone. And if you have injected this patient, okay, if you have injected this patient down here, you would cause a major disaster to this patient, and you would need to melt it. So this has not only treated her nasolabial fold, but also equalized the fullness that she has. We're camouflaging. A lot of times when you're using fillers, you're camouflaging, okay? So that's the nasolabial fold injection. What the patient, God forbid, might have, as I mentioned, they'll have pain. If you inadvertently hit the vessel, they'll have pain. You might want to tell them about that preoperatively. Okay, so the last area we'll inject on this side is the tear trough area. Marking pen. In this area, I always use cannula. I'll delineate for you, the area that you want to treat. It's this depression. Okay? So this depression is where the muscle is attached, or there are attachments between the muscle and the bone. And what you want to do is to try to fill up this area to get rid of that depression. What we do in the operating room is we open a subciliary incision on the skin, we elevate the skin and the muscle, and we dissect through that layer, through that depressed area. And we transmit, or I transmit the fat from the pocket, I open the pocket, I transmit the fat to the area to camouflage it again. But that's a permanent treatment. We can use fat as well in this area, and we can use fillers. So fillers and fat, I believe they're camouflaging the area. You can buy time with the patient until she needs that operation at some point of time.
So you're going to inject under the muscle?
I'm going to inject under the muscle. I go with a cannula, depending, so we have a 5 centimeters cannula. I usually go lateral. So this is my first injection site. If she has the depression only medially, I might go through the same site, but in her situation, she has more lateral depression here, so I want to go more lateral with my injection. I'm using 25 today. If you go narrower than 25, it doesn't differ more from the needle, and you can inadvertently inject the vessel. Half ml on one side. I never exceeded half an ml. Okay, can we have a closer view? You can see that depression over there. It's very clear. Marking pen. Much more improved. I wouldn't inject more at this point of time. I'll tell her, don't worry about it. It'll improve. If it doesn't, come back in a week and I'll inject more. But at this point of time, I'll just stop. She will develop swelling. I tell all my patients with fillers, they develop swelling for 2 days and then they improve. Okay, So how are we doing with time? Should I inject the other half or do the lips?
You want to do the lips?
I can do the lips. I can do the other half بعدين. Okay, perfect. نص لا ما حسيبك حسيبك بعد لا inject.
Trying to look at